Now, let me talk a minute about health care reform before I talk about that. There is no question that health care costs represent the single largest threat to our fiscal future. There's no question. There's no question it's not just a federal problem, it's also a state problem with Medicaid. There's also no question that it's a major competitiveness problem for American business. There's also no question it's an increasing concern of American families. That's all true. It's, to me, an outrage that this country spends twice per person what other industrialized nations spend, and we get below average results. We have below average life expectancy, above average infant mortality, above average medical error rates, and way above average obesity, which is a leading indicator of heart disease, diabetes, joint problems, etc. Okay? So our health care system, if you want to call it a system, it's not an issue of whether or not we're spending enough money. We're spending too much money. But we're getting below average results. Something's wrong. By the way, there's another system that has the same attributes. It's the K through 12 education system. We spend more per person than any other country, and we get below average results. That means you can't make incremental, modest reforms. You have to engage in dramatic, transformational reforms. If you wanted to call our health care system a system, let me give you an analogy, which is particularly appropriate, I think, given the recent housing problems that we've had. And Florida's been hit pretty hard with housing challenges. Let's say our health care system was a house. Let's call it the White House. It's built on a sinkhole of sand. The foundation is cracked. The plumbing leaks. The roof needs to be repaired. And it's mortgaged for more than it's worth. So figuratively, it's underwater. Stated differently, it's been condemned and it's going to be foreclosed on under our current path. All right? So rather than taking steps to dramatically change it, to make it habitable, and to take steps to make sure that we can make our mortgage payments for today and tomorrow, we're going to add a new wing on. Let's call it the north wing or the south wing, because we already have an eastern or west wing. Let's add a new wing on. We're going to build it out of the same flawed materials. And maybe we're going to pay for it over 10 years. Maybe. Look for the wink. But what about beyond 10 years? And the simple fact is that even if we do pay for it for the next 10 years and beyond, the fact is it's attached to this house which has been condemned and which is going to be foreclosed on. How can we call that progress? I mean, it isn't really that complicated. All right, now don't get me wrong. We need universal coverage for a basic and essential level of care that's appropriate, affordable, and sustainable over time. And in my opinion, that's preventative wellness and catastrophic. That's what it's preventative wellness and protection against financial ruin due to unexpected catastrophic accident or illness, no matter what your age is. And if you want more than that, you ought to be able to get it, but it shouldn't be guaranteed by the government, because it'll bankrupt us. We are the only country, only major industrialized country that writes a blank check for health care. The only one. Everybody else has figured out it'll bankrupt you. Even Sweden, which has socialized medicine cradle to grave, and I'm not advocating that, has a budget for health care. They don't write blank checks. And by the way, some of the other countries that have national systems, like the UK, they have private systems too. It's not an all or nothing kind of situation. We have to get costs under control. And to get costs under control, it means we're going to have to change how we pay. We're going to have to move away from fee-for-service. Why? Because fee-for-service has a perverse incentive. The more you do, the more you make. The more you do, the less likely you're going to get sued. So the more you do. All right? I mean, human nature. That's what it is. I mean, you would expect it to operate that way. It's got perverse incentives. All right? We've got to move to capitation type approaches or alternative payment approaches, which totally change the incentives. We've got to go to evidence-based medicine. Death panels are an outrage. People that say that we're talking about death panels, that's an outrage. But let me tell you what's not an outrage. We've got to deal with end-of-life care issues. 30% of Medicare's costs are in the last year of life. All right? And the fact of the matter is, when you have limited resources, you have to make tough choices over the allocation of those limited resources. In most every other country, including with national health care systems, physicians make decisions about how to allocate limited public resources, I mean on the word public resources, limited public resources based upon whether or not those treatments or other aspects will meaningfully improve or extend life. Now, you ought to be able to do whatever you want with your own money. But there's a difference when you're talking about the public's money. We have to have evidence-based systems. We have to. We've got to look at our tax system. The largest tax preference in the Internal Revenue Code, with almost $300 billion a year in lost revenues, is the fact that very few Americans pay income tax or payroll tax on employer-provided and paid health care. Almost $300 billion a year in lost revenues. Now, what does that mean? Well, first, it encourages Cadillac health care plans, but the thing that's probably more, and it disconnects people from the true cost of health care, it holds down pensions, it holds down wages because health care costs are out of control. I mean, it's part of total compensation. But let me tell you what it really does. Let me get you this picture. Let's say you're a CEO for a major company, and you're in the top marginal tax bracket, and you got a real lucrative health care plan. Under our system, the taxpayers subsidize your health care big time. But on the other hand, let's say you're near poor, working in small business, don't have any health care coverage, and you're not eligible for Medicaid because you're working. You get Shinola. That's a sophisticated Southern term. You get nothing. That's our system. Let me give you another example of something we're going to have to do. Medicare. The Medicare Part B program, which is primarily physicians and outpatient, and the Medicare Part D program, which is prescription drug assistance, on average, the premium that people pay for those voluntary programs, they are voluntary programs, cover 25% of the cost. 25%. Who's paying the other 75%? Your kids and your grandkids, with interest. Now, it might make sense to have a 75% subsidy for people who are near poor and aren't eligible for Medicaid. You can see that, all right, needs-based. It makes no sense whatsoever to have a 75% subsidy for middle and upper income people who voluntarily take this program. That's an example of how government wants to try to make very liberal promises that are fiscally irresponsible. And they're about to do it again. You know, we already have $38 trillion in unfunded promises for Medicare. $38 trillion in unfunded promises for Medicare. And what are we doing to try to be able to make sure that we're going to be able to deliver on those promises?